So, if you are ready, then we will start this case. Let's get 5 minutes of reading time, and your time starts now. Case 2. Candidate Information. Instructions. Review the following patient record summary, clinical examination findings, and investigation results. Your examiner will ask you a series of questions based on this information. You have 15 minutes to complete this case. The time for each question will be managed by the examiner. Patient record summary. Name, Albert Fletcher. Age, 8 years. Gender, male. Indigenous status, not Aboriginal or Torres Strait Islander. Allergies and adverse reactions, nil. Medications, nil. Past history, nil significant. Social history, primary school student. Enjoys playing soccer and video games. Lives with parents and younger sister. Non-smoker. No alcohol or drug use. Family history. Father with type 2 diabetes. Mother with hypothyroidism. Vaccination and preventative activities. Up to date with all routine vaccinations. Regular health checkups. Scenario. Albert Fletcher, aged 8 years, presents to your clinic with his mother. Over the past week, he's experienced increasing thirst, frequent urination, and fatigue. His mother reports that he's lost weight despite having a good appetite and has been more irritable and sleepy than usual. Today, Albert complained of a stomachache and had an episode of vomiting. His mother is very concerned and wants to know what might be causing these symptoms. Clinical examination findings. General appearance. Thin, appearing tired and slightly dehydrated. Vital signs. Blood pressure, 95/60. Heart rate of 110, regular. Temperature of 37.3 degrees Celsius. Respirate of 22. Saturations of 98% on room air. Cardiovascular examination. Heart sounds, normal S1 and S2, no murmurs. Peripheral pulses, normal with no edema. Respiratory examination, clear breath sounds bilaterally. Abdominal examination. Soft, mildly tender, no organomegaly. Neurological examination. Normal cranial nerve function, reflexes, normal. Skin examination. Dry skin, no rashes. Investigation results. Blood tests. Glucose, 25 millimole. High. HbA1c, 12. Arterial blood gas. pH, 7.2. Low. HCO3, 15. Low. PCO2, 28. Low. PO2, 85. Normal. Ketones, 4. Elevated. Electrolytes. Sodium, 135. Low normal. Potassium, 4.8. Normal. Chloride, 98. Low normal. Renal function. EGFR, 90. Normal. Creatinine, 60. Normal. Full blood count. Hemoglobin, 135. Normal. White blood cell count, 8. Normal. Platelets, 250. Normal. Urinalysis. Glucose, 3 positive. Ketones, 3 positive. Okay, your reading time is up. Your case time starts now. What do you believe the diagnosis or differential diagnosis to be for Albert's symptoms?
So and this is a case of 8-year-old male, and he is presented with something very acute. So considering the differential diagnosis, top of the list will be the diabetic ketoacidosis, and I think this is a diagnosis in this case. Beside this, I'll be thinking of other diagnoses like maybe some infections going on. However, consider that the patient has a glucose which is quite high, 25, hemoglobin A1C is high, and then he got ketones 3 plus. So it's an acute emergency, and I'll put diabetic ketoacidosis on the top of the list.
What red flags would you be looking for on further physical examination?
So on further physical examination, I'll be looking for any dehydration, and if there's any fever, if the child has some vomiting, and any ketone breaths. And then obviously have to do the general physical examination. I'll focus on the abdominal examination also, look for any tenderness there, or and any other signs of dehydration.
Yep. Would there be any additional questions you would want to ask that might help narrow down the diagnosis?
I will, first of all, because they say that the patient has been experiencing over the past week, there's increased thirst and frequent urination. I like to dip a bit deep in that one and like to ask some more information about what they actually mean by the increased thirst and how frequent is the urination and fatigue that is present for the past week. I'll be very much interested in knowing about any previous history of fever, any gastrointestinal symptoms, or any illness, because all these things um, can cause diabetic ketoacidosis. Obviously, this is a patient which has diabetes but was undiagnosed, and it has presented an emergency situation with diabetic ketoacidosis. So I like to do the complete history. I know that there is a family history of type 2 diabetes, and the mother has also an hypothyroidism, so got some autoimmune disease also. So I'll take a bit more about the family history, and then I'll also ask about any previous investigations done or any other relevant information regarding the child. Also will be interested in knowing about the vaccination history of the child, and was there any concern raised in the regular checkup before or any other relevant things.
What's your immediate management of this child?
So this, as you know, that this is an emergency. So this one I have to um, refer. Actually, thinking about the referring the patient immediately to the emergency department. However, for the initial management is actually fluid resuscitation. Fluid resuscitation. So I like to start with the isotonic saline. I like to administer about 10 to 20 ml per kg bolus over 1 to 2 hours, and I want to reassess the clinical status after the bolus, and then I would like to calculate any fluid deficit. How much is it? Maybe usually these patients with diabetic ketoacidosis, they do have dehydration about 5 to 10%. And that will be obviously our plan will be to replace it another 48 hours. Another important aspect is I like to start insulin. So we'll begin with the low dose continuous IV insulin infusion from 0.05 to zero point 0.1 units per kg per hour after the fluid bolus. And we will avoid any initial giving an initial bolus of insulin because we want to prevent any rapid shifts in the osmolality. I like to monitor the blood glucose. So When the blood glucose falls below 250 to 300 milligram per deciliter, I like to add the dextrose to the IV fluids to prevent any hypoglycemia while continuing the insulin infusion. I also like to monitor the serum potassium. So if initial serum potassium is normal or low, I want to start the replacement of the potassium with the 20 to 40 milli equivalent in IV fluid once urine output is established. And if the potassium level is high, well, then I will delay the potassium replacement until the level normalizes. And I like to frequently assess the patient, assess the vital signs, assess the patient's neurological status and clinical response every 1 to 2 hours. And my plan will be to repeat the labs, electrolytes, and the EBGs. I like to repeat it every 2 to 4 hours. And I'll be very vigilant to look for any signs, like especially the signs of the cerebral edema, which includes like sometimes altered mental status, or patient may have some bradycardia or high blood pressure. And but for this patient, obviously we're going to start the fluids and anything, but diabetic ketoacidosis has to be managed in the emergency. So I will, in the meantime, I like to prioritize alert the A&E department about the patient. I'll also like to talk to the medical on-call or the emergency on-call personnel to give me some guidance about the further steps regarding this patient, and then like to shift the patient as early as possible to the emergency.
Very good. Now, how would you explain the diagnosis of diabetic ketoacidosis and the diagnosis of type 1 diabetes to Albert's mother?
Knowing that there is some background knowledge is already there, the mother knows about the diabetes because father has already got type 2 diabetes. So here I have to explain to the mother that most likely the patient has type 1 diabetes. And this is quite different from the type 2 diabetes, because this one will require lifelong insulin. So I will explain to them that what is the difference between type 1 and type 2 diabetes. And most likely this acute presentation is because of the diabetic ketoacidosis, which is one of the complications of diabetes. And then I like to explain to the mother about the further management, that what I'm going to do, what is our plan now. So our plan is to shift the patient to the A&E, get the blood glucose down, give some fluids. So I'll explain everything to the mother. And regarding the diabetes, I will also explain to them about the future plans, about the complications, and any support which is available to help them cope with this new diagnosis, and how we can help with the child and also the mother.
Good. What can you tell me about monitoring devices or options for monitoring glucose levels moving forward from after this initial resuscitation?
So ideally, the type 1 diabetes patient, they should be well aware about monitoring of the blood glucose, self-monitoring using the glucometer. That one they should be very well aware, the whole family actually. So regarding the monitoring devices, we can use the normal glucometer, and sometimes we can use even some of the glucometers that can tell us about the ketones level as well. So that will be quite helpful for them to monitor the patient condition. And especially when we are putting on the insulin, we also give them all the red flags that should watch for when the patient is having some hypoglycemia, what to expect, and how, if the patient condition is like this, like now he has presented emergency, if something happens like this, he becomes acutely ill, maybe they can have some knowledge about how to check the ketones, either with the glucometer, or maybe they can check in the urine as well. If it is not possible, how should we proceed further about this? So the monitoring is actually quite important, and I will like to emphasize this to the mother, and that how we should.
What kind of methods do you recommend for glucose monitoring?
Actually, we can use the normal like the glucometers we use, skin prick. We can check the blood glucose, and this is actually the most common method which is used actually.
Are there any other devices you're aware of that might be useful for a child?
I think I'm not sure actually.
That's okay.
Maybe I don't remember now.
What do you think the follow-up plan would be for Albert once he's discharged from the hospital?
So follow-up plan will be mainly will be the education to the whole family actually, and also to the child as well. And in diabetic education is actually a broad thing. So we have to tell them about the glucose monitoring. Also have to give them idea about the insulin administration, signs of hyperglycemia, hypoglycemia, dietary counseling. So we have to develop some meal plan which is more tailored to the child. Maybe refer to the dietitian will be a good idea. And beside this, the patient will need some psychosocial support as well. Not the patient, the whole family will need some psychosocial support. So it will be a good idea to refer the patient for the psychosocial support as well. I like to refer this patient to the endocrinologist. And so regular meeting with the endocrinologist will be important. And I like to follow the recommendations of the whatever recommendations they given by the endocrinology department. Hemoglobin A1C testing will be very important. So it will be planned and should be done every 3 months to assess the glycemic control of the patient. Another thing is about I think about the adjustment of the insulin therapy. So I like to we will have to teach the mother about the review and just insulin based on the glucose monitoring data, and we have to address about the any insulin administration techniques or adherence. And obviously, the continuous diabetic education is important, focusing on type of diet and managing the diabetes during illness also will be important. Beside this, I like to screen for other autoimmune conditions here as well. Particularly, I'll be thinking about the celiac disease. So I want to screen for that one as well. And ongoing support is important in this patient. We will like to enroll the patient in some diabetes self-management education. Patient also needs a school and community support. I like to make I will ensure that the school is informed about the child diabetes, and we have some action plan in place at the school. And also, I want to connect the family with the local diabetes support and the resources. And I also want to educate the patient on managing diabetes during emergencies or when they are traveling. And on another thing is I like to provide a glucagon emergency kit, and I want to ensure they know how to use it in cases of emergencies. So regular monitoring is important. Lifestyle and nutrition is important. Healthy, balanced diet. Vaccination, I will ensure that the child is up to date with all the vaccinations, including the annual influenza vaccine.
Very good. You have 10 seconds left on the clock. Is there any further information you would want to provide?
So I think this is actually an emergency case. So I'll be very vigilant, and
And your time is up. Well done, well done. How do you feel? How do you feel you went?
Yeah, I think it was okay, but still, I think I missed some points and missed some answers actually.
I think you smashed it out of the park, to be honest. Do you work in emergency, or have you worked in emergency previously, or do you work rural?
Yeah. I worked in emergency.
Yep, you can tell. You obviously were very comfortable with the management of DKA, and I thought that was really good the way you stepped through. You knew exactly what to monitor. And while for a GP exam, we'd normally want you to know the basics of that, the fundamentals of that. The fact that you knew exactly was absolutely spot on. So very well done there. And feel free to tap into that extra knowledge you've picked up from other areas as well. Because again, it does show that as GPs, we are experienced, we are polished in multiple domains. And so you absolutely nailed the diagnosis and the management there. I liked as well that you spent a fair bit of time going through that, community management, the ongoing kind of plans there. You touched on the psychological side of things as well, which, can get missed for kids. And it's such an important thing. We see so many adolescents in particular that come in with a recurrent DKA because, to be honest, they're sick of diabetes. They're sick of it kind of managing their life. And so if you don't get in early, it does make a very big difference. Well done. The continuous glucose monitoring devices, have you seen or heard of any of those?
Actually, yeah, because but what we are doing here is because I'm actually working in Brunei, so this is what we have actually.
Yep, fantastic. Yeah, good. Yeah. Because when you say glucometer, most people think of just the standard kind of finger prick, which particularly for younger kids, they get sick of it pretty quick. So throw in the continuous blood glucose monitoring devices. And you can mention as well, the parents can get apps. We can download the data to titrate treatments much tighter. Free marks, basically. But again, as long as you have a sensible kind of monitoring plan in place, I think you're going to be fine there. Again, you knew who to refer to in terms of pediatric endocrinologists. You knew, the ongoing follow-up that was going to be required there. Have a quick look at the other questions. There was a couple of questions that I didn't actually fully ask because you'd already answered them as we went. And this case in particular was set up, the questions kind of lead into each other. And so you'd already started answering some questions as you were finishing up other ones. So when that happens, and in a case like this, where the examiner will manage the time, if you're already answering that next question, sometimes they will just kind of let you go, as I did. Sometimes they might quickly interrupt and actually say, oh, on that note, here's the question. So if you feel like it's been a long time between questions, that's probably a sign you're on the right track. Remember, before these, the examiner's managing the time for you. The probably only other thing that I had here was... No, you mentioned the dietitian. You did get that in there. And you did sneak in at the end there as well about the glucagon pens as well for hypoglycemic management. Well done, mate. Smashed it out of the park.